Welcome to Get Moving TV. I'm Dr. Chris Landon. I serve as your host. We're going to have a special 56 minutes coming up. What we're trying to do is educate the physicians in our town, in our county, about chronic obstructive pulmonary disease. But I think that it's at a level where the entire community really needs to understand what's going on. We have some 28,000 people in Ventura County, and we know about maybe 3,000 or 4,000 of them who suffer every day from shortness of breath, don't understand why they just don't want to take the stairs anymore. What's come up recently is what's called World COPD Day, or Chronic Obstructive Pulmonary Disease Day, because this is a problem internationally. When I go down to the Honduras, what I see are biomass being burnt to try and keep down the mosquitoes for malaria. When we look at China, we've got all kinds of new market for tobacco. And with that comes lung cancer and permanent lung disease. So as we start off on World COPD Day, November 19th, what we're going to go over is we really want everyone in the community to learn, not just the physicians. So we're going to talk about what is COPD, what are the risk factors and the symptoms of COPD, what's the pathophysiology. This is a nice long doctor word, but what it means is what is it about the change in your own anatomy that causes these problems? What's the difference between asthma and COPD? Oftentimes I have patients come in my office and they have asthma and they were exposed to smoke years ago and want to know what the difference is. So we're going to talk about that. What are the global strategies in diagnosis, management, and prevention? And finally, how do we diagnose and assess it? So in this first segment, we're going to talk about COPD. Now, it's a common, preventable, and treatable disease. It has persistent airflow limitation, so there's an inability of air to move through your tubes. It's usually progressive, and it's associated with a chronic inflammatory response in the airways, swelling in the airways, kinds of cells that cause damage, and it's in response to noxious gases and fumes, like cigarette smoke, but also industrial waste, burning of biomass to keep away mosquitoes with smoke and fumes. Now what happens is exacerbations or made worsenings, comorbidities, so problems with heart disease, overweight, all these can add into the overall severity for patients. But all kinds of things go into it. One thing is, in the United States, there's about 100,000 people with alpha-1 antitrypsin disorder. With that, the onset of COPD is at a younger age, it's in the family, but mainly for us here in Ventura County, it's going to be exposure to tobacco smoke, occupational dust. We're in an agricultural county, so indoor air pollution. So we see this even more so in South America, where we see indoor heating. But in our poorer sections, in Oxnard, with farm worker housing, we may see heaters used indoors, exposing the children and adults to noxious gases. Outdoor air pollution is a problem. It used to be worse, but we think of Ventura County and particularly Ventura as being right up against the beach, but that airflow traps the smog. It affects our lung growth and development. Exposure to smoke even in utero while people are pregnant can affect your lung growth. Females tend to do worse than males. So if you've had this, you've been a female lung smoker, it's going to be a problem. Elderly, we tend not to see this disease until 45, 50, and beyond. Socioeconomic status, if you don't have access to medical care, and that's really what we're looking to fix, there's a component of asthma as well, and chronic bronchitis, so constantly bringing up yellow, purulent sputum. So it's a chronic problem, it's a progressive problem, sputum comes up, and this is made much worse with exercise. Chronic cough, much like I seem to be having now, can be intermittent and unproductive, or you may just be bringing up sputum at all the time. So when we look worldwide, it's the #1 cause of combined morbidity and mortality. People die, but every day their lives are affected by this disease. So it's divided really into two big parts: small airway disease. So as you look at our trachea, it's about the size of your pinky, breaks into 3 big tubes on the right, 3 on the left. Those tubes divide, 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 divide. And if I said divide 28 times, that's how many times your lungs divide. At the end are little air sacs called alveoli. And in those, if you can imagine a bunch of grapes, and the stem is hollow, those grapes are little air sacs in there. But what happens with this COPD is there's a breakdown in those grapes. So if you can imagine a little grape, that'll move a lot, you'll move a lot of air, but if it's one big one, it's really hard to get much air through. So what you see here is a normal alveolar wall, or that little grape, that final air sac, compared to what happens in emphysema. So you can see how thick that wall is, how difficult and narrowed that airway is. Asthma is different from COPD. With COPD, you can have asthma, but the kinds of cells that come out are different. There's an allergic cell that comes out in asthma called the mast cell. That's the main effector. Eosinophils, a kind of white blood cell, come out. And also kind of a response to the body called a CD4 T cell, as well as macrophages. When we compare that to COPD, that's mainly the neutrophils. These are the kind that fight off bacteria, and as they're pumping out hydrogen peroxide into your lungs. So if you've ever smelled hydrogen peroxide, you know that's not the best thing for any tissue. A different kind of cell called the CD8 comes out, and macrophages. Macrophages are running around chewing up the noxious, well, look at an ashtray. You wouldn't lick an ashtray. Well, that's what you're putting into your lungs. The mediators in asthma are different. Histamine is a major mediator. There's what are called the leukotrienes. The LTD4 is a big one, the interleukin 4 and 5. So these, it's a different set of molecules, and the treatment is different. In COPD, it's a more matter of inflammation, the LTDB4, interleukin 8, and so the medications, which are very complex and ultimately expensive, it's different in COPD than asthma. So here we see the air trapping that occurs, so that narrowed airway leads to this expanded airway. So as you inspire, take a breath in, decrease the pressure in your chest, open up the airways, and then out it goes. While you see in COPD, there's swelling and the air gets trapped. So you feel this bloating, these blue bloaters we call them, because they're not exchanging air very well and the chest is big. As we look at the global obstructive lung disease measures, we have people who are at risk, people who've smoked for 10 years or more, or over the age of 45, and then those who start to have problems, whose air is starting to be restricted, and then finally, as we move along with more destruction from neutrophils and macrophages, finally, those are the people you see who are in the wheelchair and with the oxygen. The other problem is that our body then starts to fight itself off as well. So something called acquired immunity, the T cells and B cells are involved in continued destruction of the lung. So just the key points. So for diagnosis, we really need to ask the question, and you need to go to the doctor when you have these symptoms. Don't stay at home. We have things to make you more comfortable. Those symptoms will be dyspnea, a chronic cough or sputum production, and then exposure to risk factors in industrial or cigarette smoking. Now what we'll be doing is throughout the county, the clinics will be learning how to do spirometry. This is a test in which you take a big breath in and blow it all the way out. And with that, if there's a difference between the amount of air that you can get out in 1 second and your forced vital capacity, that biggest breath in to that biggest breath out, if that ratio is less than 0.7, then we need to do some more complicated pulmonary function. So we really want everyone over the age of 40, pack smoking more than 10 years, to be getting at least this basic screening so that we have an idea of how to attack this particular problem. So in summary, we've started talking about what is COPD, the pathophysiology, the differences between asthma and COPD, some of the risk factors and symptoms. We've begun talking about global strategies and the diagnosis and assessment. Welcome back. Well, we've been talking about World COPD Day. We're really working on raising COPD awareness worldwide. We've gone over what is COPD, risk factors and symptoms, pathophysiology, the difference between asthma and COPD, some global strategies, and the beginnings of diagnosis and assessment. So really what we want to do is classify severity. When you're told you have COPD, if you're at a global obstructive lung disease stage 1, that's much different from stage 4. People imagine themselves as being on oxygen right away. Really what we want to do is stop that downward slide, and that means stopping smoking. We're going to talk about assessment of COPD, risk for exacerbations, combining assessments, the comorbidities, and really, again, the differential diagnosis between COPD and asthma. So here's what we're looking for. We talked about spirometry. That was that biggest breath in to biggest breath out, and how much air you can get out in that first second. So if you have this 10-year pack history of smoking, your FEV1, the amount of air you get out in the first second, for your age and height and weight, if you're over 80% of predicted, time to stop smoking. Time to get your flu shot. Get your pneumococcal vaccine. As we look at gold stage 2, now you've affected your lungs. You're less than 80% of predicted. You may be as low as 50% of what we'd expect. Hopefully, after a bronchodilator, your lung function is improved and the medications are going to be helpful. Now, as we move more severe, so my patients who are at moderate and said, I just don't want to stop smoking. Now they're at 50% to 30% of their lungs. So if you can imagine 2/3 of your lungs is thrown in the trash, makes it awfully hard to get upstairs, makes it hard to wash the dishes, makes it hard to walk to the car, makes it hard to leave the house. And then that final gold stage 4, the very severe, you really need to make some decisions about your life. The amount of therapy that it's going to take, the amount of improvement you'll get even with aggressive therapy. You've reached some very difficult decisions and need to talk that over with your doctor. So when we assess symptoms, we're also looking at a history of exacerbations. The spirometry, of course, we want to make sure that you're having this measured in terms of your therapy, that you've improved or at least stabilized. The problem is if you have 2 or more exacerbations within the last year, your FEV1 is less than 50%, so you've thrown away half your lung. These are predicting a high risk for going to the hospital and even a risk of death. So we use that combination of exacerbations and spirometry, so how that air is moving through. And again, 1 or more hospitalizations for COPD should be considered a high risk. At our hospital, we are putting in place, through our respiratory therapy program, a respiratory care manager. No patient will leave the hospital with a COPD exacerbation without education, without knowing how to use the medications, if they need a nebulizer, if they need home oxygen. And then we have a program of 4 nurse case managers as well as 2 community health workers who will be doing home visits. The Livingston Visiting Nurses Association is going to be doing home visits. We're going to be involving people in exercise through the Better Breathers Clubs. So when we look at this combined assessment, we can kind of break it into those 4 quadrants that you see. We're looking at A, low risk, less symptoms, little limitation, maybe 0 or less than 1 exacerbation a year. And in terms of looking at how you feel, your life is unaffected. If we do a questionnaire, you can go to your car, you go out in public, you can do your chores around the house, you can walk upstairs, so you don't really feel a sense of breathlessness. Low risk, but more symptoms, now you're starting to have more problems in terms of your activities around the home. As we move into high risk, so people who have continued to smoke or in gold stage 3 and 4, are having those 2 exacerbations a year, but still are able to function well, we have to introduce more therapy. As we move into the high risk, more symptoms, these are the people who we call frequent flyers. They're in the hospital frequently, particularly during the winter months. Now, the other problems are that COPD is generally not found all by itself. We have cardiovascular disease, we have osteoporosis, so a loss of calcium in the bones, recurrent respiratory infections, and not being able to get your breath will bring out anxiety and depression. And with that comes not complying with medications, not going to doctor visits, not taking care of yourself, not eating properly, not exercising. Diabetes, lung cancer, and what we call bronchiectasis, which is the lung inside the lungs, the little hair-like cells called cilia. There's now scarring and that mucus piles up. It's like leaving a glass of milk out. It's just an easy place for bacteria to grow. And all those things will additionally affect that mortality and the hospitalizations, and they need to be looked at routinely. So having a primary care physician who's keeping track of all your problems as well as helping you to stop smoking, giving you access to medications, and getting access to home care, particularly if you've been hospitalized. So when we take a look between COPD and asthma, the COPD we tend to see more of that onset later in midlife. The symptoms are slowly progressive, and generally there's a long smoking history. Maybe less so the industrial exposure, but we have people who've worked in foundries and so forth. With asthma, I tend to see it more in childhood. And people can outgrow their asthma, then they tend to grow back into it age 35 to 45. We fall apart a little bit. With asthma, the symptoms vary more day to day. Because of our own body's adrenaline and steroids, the symptoms tend to be worse at night. Doctors close their offices, so fevers are up at night, coughs are up at night. That's your own endogenous steroids and adrenaline. With asthma, there's additionally allergic rhinitis, so hay fever, an allergic salute, eczema, terribly dry skin, and oftentimes a family history of asthma. So in summary, really what we've been looking at now is classifications of severity, assessment of COPD, the risks for exacerbations. We combine the assessments for asthma and COPD. We've talked about the comorbidities and the differential diagnosis between COPD and asthma. So we're going to be right back. Welcome back. What we're going to be looking at over the next 15 or 20 minutes or so is classifications of severity, assessment of COPD, the risk for exacerbation, combining assessments, the comorbidities, the differential diagnosis. We're going to continue on this theme. What we want to do is make sure that you're getting a complete workup so that we're looking at the other potential causes. We want to have a differential diagnosis. What are the other things that might be bringing up purulent sputum, making you cough, making you short of breath? And then what are the therapeutic options? How can we reduce your risk? How can we help you to stop smoking? Are there surgical treatments? And then the pharmacology and other medication treatments. So smoking cessation is the greatest capacity to influence the natural history of COPD. If you don't stop smoking, you are looking at a relentless downward progression of dyspnea, cough, purulent sputum, and by stopping smoking, you can at least arrest that or maybe even improve your symptoms. So our job as healthcare providers is to help you through this. There is pharmacotherapy, there are nicotine replacement patches, and these will reliably increase that long-term abstinence. Heroin and cigarettes, recidivism is the biggest problem. So through our public health department, through the American Lung Association, through this program, we're going to provide you with the resources, including the pharmacotherapy and nicotine replacement, if that's what it takes. And we need you to have you stick with it. Now the other thing, through the Better Breathers Clubs and other resources that we'll be developing, we know that regular physical activity needs to be encouraged. You need to remain active. So the most important thing here is going to also be seeing a physician who's going to prescribe appropriate pharmacologic therapy. Just going in and getting an albuterol inhaler at your emergency room whenever you feel sick, there are other medications involved that can help to control symptoms and really reduce the severity, reduce the amount of time that you spend in the hospital or return to emergency rooms. The medications, though, do not prevent the long-term decline. You must stop smoking. The other things that we can do, we want to make sure 100% of people have done this, and that is influenza and pneumococcal vaccination. We need to have it. The higher dose influenza vaccine, the second type of pneumococcal vaccine, and as we age, like myself, we may need boosters if you received it earlier in life. What we know about cigarette smoking is if the doctor can spend as little as 3 minutes talking to you about this, encouraging you, doing motivational interviewing. It has to be important to you that you stop smoking, and then for you to look at your day. How can you not have cigarettes in the house? How can you avoid dangerous places where you're going to start smoking again? And then working with you to see how those pharmacologic therapies, the gums, the inhalers, the nasal sprays, the transdermal patches, the sublingual tablets, the lozenges, and then there are other medications you can take by mouth, one of which was used in depression, but it turns out it's very helpful for people who want to stop smoking, and they're more effective than placebo. So our job as physicians is to ask, advise, assess, assist, arrange. So we really want to, if we don't ask, don't tell, we need to ask. We need to identify tobacco users. We need to advise them, really urge people to stop smoking. We need to assess, are they willing to stop smoking? And that's that motivational interviewing. It's got to be the patient's decision. You can help them. You can't do it for them. Then we need to assist them by prescribing medication or continued counseling, making interventions through community groups or telephone numbers. And then we need to schedule that follow-up contact. In terms of reducing risk, as a community, as we head out as physicians in the community, as community members, we need tobacco control policies. We need to control it in bars, we need to control it in movie theaters, in public places, and it needs to be clear and consistent and repeated non-smoking messages. This needs to come from our city councils, needs to come from our county government, needs to come from your medical association, American Lung Association, Livingston Visiting Nurses, everyone involved. We need to make this clear, consistent message. And then in the workplace, so we can do this by eliminating smoking in the workplace, having people smoke out by the trash can. Well, we want them out of our way. We want people to stop smoking and not being exposed. Then indoor air pollution from biomass fuels that we've talked about. This needs to be included with our advice to our farm workers who may not have a heater, who may be burning biomass, burning for cooking and heating in a poorly ventilated setting. Then we need to advise patients to monitor air quality measures. So as we look at the therapeutic options, we have a number of them. We have what are called the beta agonists, and those are there to help open up, relax the muscles around your bronchial tubes. They can be short-acting or long-acting. We have what are called anticholinergics. So as you've affected the nerves in the lungs, can we calm those down so they don't tell your lung to go into spasm? There are combinations of telling the muscle to relax as well as telling it not to spasm. We have combinations in one inhaler. We have what are called the methylxanthines, which are more from my day. These are the theophylline, the Theodor, the Slobid, that used to be a lot more popular 30 to 40 years ago. Inhaled corticosteroids can be of benefit, particularly if someone has asthma, but a combination therapy of long-acting beta agonists, a long-acting form of medication that relaxes those muscles, as well as inhaled steroids, seems to be the most effective. Taking steroids by mouth may be helpful for short periods of time, but we don't want to cause cataracts and collapse of the bones of our spine and problems with sugar diabetes. And then phosphodiesterase 4 inhibitors, these are some of the newer medications that someone, as an adult pulmonologist, if you have the stage 3 and 4 disease, these are the drugs you may be using. So again, bronchodilators are central to COPD. They're prescribed oftentimes as needed to prevent or reduce symptoms. You might end up using them before you go up the stairs if you're severely affected. These drugs are the beta-2 agonists, the anticholinergics, the theophylline, or a combination of these. But these things depend on the availability, what's on your formulary. And in countries we travel, we've been to Peru, we go to the Honduras, all I may have is a form of beclomethasone and a form of albuterol, and that's it. So we make do with what we have. We're a great advantage here in the United States. Now the nice thing about the longer acting ones is they're convenient. Just twice a day, people need to remember to take them. Sometimes I'll duct tape them to people's toothbrushes. We need to wash our mouths out after, get the steroid out of the mouth. We want it in the lungs. And they are known to reduce these exacerbations, these MAID worsenings, reduce hospitalizations, improve symptoms and health status. And so by combining the two, the long-acting beta agonist and the steroid, we can see a great deal of improvement or at least control of symptoms. Regular treatment. So this is when my patients come in the office, I go, oh, are you using your medicine? Well, you know, I use it kind of when I feel bad. I go, oh, did you come here in a car? Why, yes. Did you wear your seatbelt? Yes. Oh, I'm sorry, did you wear it because you got in an accident? Well, that's really what we're looking at. We need to use these things ahead of time. Think of them as the seatbelts for the lungs. There is an increased incidence of pneumonia associated with these, and if you have a fever and a cough, even if your symptoms have been controlled, you need to be seeing your physician right away. and stopping the medicines because you can't afford them, or you didn't make it to the physician's office, or it was time for a refill and your doctor wanted to see you before refilling the medicines. This is where the case managers hopefully would be assisting you, because we need for you to be taking your medications. So again, the combination therapy is the most effective. We have that increased risk of pneumonia, and adding the two together appear to provide additional benefits. Again, chronic treatment with prednisone, steroids by mouth, is contraindicated. There's an unfavorable benefit to risk ratio. Now, in patients with very severe disease, the GOLD 3 and GOLD 4, with a history of exacerbations, chronic bronchitis, coughing up yellow, coughing all the time, there is an additional medication available now, roflumilast, which can reduce exacerbations, particularly in those patients who are treated with oral steroids with the prednisone. Theophylline, which is in tea, the equivalent to it is in caffeine, does relax the bronchial tubes. The side effects, though, can be faster heart rate, intestinal distress, faster movement of the intestine, and it has a modest effect compared to other medications. When we take a look at influenza vaccine, there's where your money is, especially for GOLD 1, GOLD 2. That may be most of what you need, is to prevent serious illness. The use of antibiotics, other than demonstrated bacteria down there, really are not going to be indicated. We can bring up mucus. It's not necessarily infected. We don't want to be culturing more and more resistant bacteria. Now, for patients, those 100,000 in the United States who have the alpha-1 antitrypsin deficiency, who had onset of COPD before age 45, or a family history of young onset, this medication, the alpha-1 antitrypsin augmentation therapy, is very helpful. Mucolytics, a lot of people like their Mucinex or like their Tessalon pearls, really doesn't seem to help a whole lot. Antitussives, people become Phenergan with codeine dependent, or Tussinex dependent. It's really not very helpful. Really, you want to get at the underlying cause. People have tried vasodilators, things to open up the blood flow through the lungs. Again, not very effective. So nitric oxide is really not something that's going to be helpful in stable COPD. But people do benefit from exercise training. So this is a way to get social, to get out, walking club, steps. If you're going to get a step ahead of dyspnea, inability to get a good breath, to get a step ahead of fatigue, an exercise training program is going to be essential. In general, especially with the Better Breathers clubs, we try to be pretty intensive for 6 weeks, and oftentimes like soldiers in a foxhole, you get to know each other and continue to support each other in terms of exercise. If you can maintain it at home, then you can maintain that health status above that 6 weeks where you participate in the exercise program. Oxygen therapy, you see people with cannulas carrying oxygen tanks, or with oxygen concentrators. For patients with chronic respiratory failure, people who are in that GOLD stage 4, it can be very helpful. It's an expensive intervention, but if it gives someone less dyspnea, less feeling where they can't get their breath, can improve their exercise around the house, so much the better. I have patients who use something called Breathe Technology, non-invasive oxygen-powered ventilation. And I have one young man who's getting set for a lung transplant. This has allowed him to keep in physical condition to allow him, until we can find a set of lungs for him. So in a selected subset of patients, this ventilatory support can be very helpful as well. So in summary, we've looked at additional investigations and differential diagnosis. We looked at the different therapeutic options and how to reduce risk, especially smoking cessation. We're going to talk about surgical treatments and other medication treatments, and Ventura. We're going to be right back. Welcome back. Well, we've been talking about additional investigations and differential diagnosis, therapeutic options and risk reduction, smoking cessation, surgical treatments, and other medication treatments. So really, if we start with how do we manage stable COPD, what are our goals of therapy, how can we avoid risk, what pharmacologic therapy can we intervene with, and non-pharmacologic therapy such as exercise, how can we manage exacerbations, and what are the consequences when you have a worsening of disease, how can we assess that, how can we treat that. So really the main thing is identification and reduction of exposure to risk factors. We got to get away from cigarette smoke. We have to watch exposure to infection. And if we're going to prevent and treat, that's really going to be the cornerstone. So if we take a look at individuals, you have to look at your own life. You can't just be looking at a computer screen and have it suggest exactly what you do. We need to know where you're going to be. We also need to take a look at what causes your airflow limitation, what causes that contraction, and we want to make sure that we're getting a step ahead of these exacerbations. And with this grant, the idea is to do that with case management and these community health workers. Everybody will benefit from rehabilitation, maintaining physical activity, and we use the pharmacologic therapy really to reduce symptoms, reduce the frequency and severity of these exacerbations, and really improve overall health status and your ability to tolerate exercise. So to do that, again, the long-acting beta-2 agonists, the ones that relax your lungs for 12 hours, the cholinergics, the anticholinergics, again, not causing the lung to contract. We prefer those over the short ones. So people you see sucking on their inhalers all the time, really we have alternatives where they don't need to do that. For some people, it's a placebo. Well, we don't want a placebo. We want medication that works, and we want it to work for your life. And so taking it twice a day is better than depending on that short acting where if you've lost it, oh my gosh, you're going to be in real trouble. So if there's a high risk of exacerbations, we want these long-acting medications. Now, long-acting therapy just using the steroids by mouth is not recommended. Just using an inhaled steroid without that medication to open up the bronchial tubes is not recommended. And again, that roflumilast, the phosphodiesterase 4 inhibitor, if you're down there with the ability to move air through your lungs at less than 50%, you've got chronic bronchitis, it can be very helpful in terms of those with frequent exacerbations or worsenings. So really what we're looking at, we want to reduce symptoms and reduce risk. We want to relieve symptoms, improve exercise tolerance, improve health status. We want to prevent this disease from progressing. I can't make it better, but I can prevent it from progressing. I can make your symptoms better, I can reduce them. And then we want to get a very early prevention and treatment of exacerbations or worsening. And we want to prevent death. We want to have a good life. We want to prevent death. And by making these interventions, we can reduce mortality. So, avoiding risk factors, smoking, indoor pollution, occupational exposure, get your influenza vaccination, and your pneumococcal vaccination as well. So when we look at the non-pharmacologic interventions, again, smoking cessation, physical activity, flu vaccination, pneumococcal for mild disease, really that's what your doctor is going to be recommending. As we move into the worst patient group, if you remember our little chart from before, patients who are having problems with breathlessness, who are having exacerbations, smoking cessation, big part of it, physical activity, a big part of it, flu vaccination, big part of it, pneumococcal vaccination, big part of it, pulmonary rehabilitation, but we really need to include the medication on a chronic basis, long-acting medications that fit in your life. So if we take a look at the different types of medications, the antimuscarinic short-acting, the short-acting beta agonists, those are really for just symptoms, and so when people have mild disease, they may be sufficient. As we move into that category B where it's beginning to affect your life, now we really want to start looking at long-acting muscarinic antagonists. We want to look at long-acting beta agonists and combining them with the steroids. As we move into those people who are having exacerbations, bringing up sputum, FEV1 is less than 50%. Now we need to be doing that very aggressive pharmacotherapy, and we have alternatives, and this is where it's time to meet with your pulmonologist and really look at more and more combined medications. As we hit D, the ones at higher risk, then that inhaled corticosteroid plus the long-acting beta agonist and a long-acting muscarinic antagonist is essential therapy. There are alternative options, but really these are the things we need to introduce into your life. So again, we're looking at symptoms. If your symptoms are at a combined scale of less than 10, your feeling of breathlessness is 0 to 1, you're in pretty mild disease, and as you see on the screen, these are the therapies that are recommended. Now, these are the alternative choices as well, so that if your insurance company or the formulary doesn't cover the exact medications that fit into those categories, these are some alternatives. And for some people, it's a matter of, well, we had one medication that worked very, very well, but it tasted like licking a car bumper. And so we complained to the manufacturer, and they put mint in it. So now it tasted like a mint-flavored car bumper. So some of these medicines, they may be hard to take, may not taste right, and so we need to look at these alternatives as well. Other possible treatments, again, especially as we move to other countries, we may be stuck with a very limited set of medications, and so we start looking at these alternatives, the carbocysteine, and short-acting beta agonists, theophylline, because we are so limited in the medications available. The expense to the government as they try and treat these people with a very damaged economy, much like we'll see in the Honduras and Nicaragua. For them, there's a very limited set of medications. So how do we define this exacerbation I keep talking about? So it's an acute event, so it's not like your everyday life. It happens suddenly, acutely. You have a worsening of your symptoms, and it's beyond the normal day-to-day variation. Some people have good days, bad days. This is going to lead to a change in medication. So you need to up your therapy when you have an exacerbation. You may know it because, oh, I had a cold, and I know, gosh, 3-4 days later, it really settles in my chest. Or for the last, about 2 weeks ago, I had a cold. I'm bringing up more mucus. I'm having more problems with dyspnea. I'm starting to lose weight. You don't go to McDonald's and order a mucus burger. You cough that mucus up and swallow it. Your appetite goes away. So if we have these COPD exacerbations, again, oftentimes it's a viral upper respiratory infection. Antibiotics aren't going to be helped. The diagnosis, you need to have, again, that primary care doctor. There's an acute change in symptoms, and that's what you need to communicate to your physician. We want to minimize the impact of this exacerbation on your life and prevent the development by getting a step ahead. If you have started smoking again, if you're not in rehabilitation, if you're not filling your medication prescriptions, that's part of the goal of a physician visit. So again, if there's an exacerbation, we may end up using more of those short-acting beta agonists and on top of your usual long-acting beta agonist inhaled corticosteroids. Maybe this is time for prednisone by mouth if there's an acute exacerbation, but again, we want it for a very short period of time. We want to improve recovery. If there is purulent sputum, then we want the antibiotics can improve recovery time, improve lung function, and get you back to where you need to be. If there is in the emergency room or in the physician's office, they check your level of oxygen with a pulse oximeter, it's reduced, you may require oxygen. And that can prevent an early relapse, a return to the hospital. A hospitalization nowadays ends 30 days after you've left the hospital. We have to pay attention to you not returning to the hospital, and this is the best way to do it. And oftentimes they can be prevented. I tell my patients this time of year, I've got Christmas, I've got Thanksgiving, I've got relatives. If there's, put a Kleenex box by the door. If it's green, tell people not to come in your house. So again, the consequences of these, it's not just a matter of some numbers on a piece of paper, it's impacting your quality of life, it's impacting your symptoms, impacts that movement of air through your lungs, the lung function. It costs money. You're missing work, you're in the hospital, increasing the cost of medications, and people in gold stage 4, particularly women, it increases mortality, these frequent exacerbations. And frequent exacerbations lead to an accelerated lung function decline. Your lung function is going downhill. So again, in the hospital, they might do an arterial blood gas. So if the level of oxygen is sitting there below 88% on our pulse oximetry, or below 65, then you're going to need extra oxygen, and you're going to need to be able to return to room air. So we don't want you to go into respiratory failure. An elevated level of carbon dioxide, particularly if you have long-standing disease, giving oxygen actually may not be helpful. That lower level of oxygen may be what's driving your respiratory drive. Oftentimes people get a chest x-ray, more to exclude alternative diagnosis. You can have a worsening of symptoms without any changes on the chest x-ray. EKG, particularly if you're older, if you're in congestive heart failure, an EKG can be helpful, or picking up a new silent heart attack. A blood count to see whether your oxygen levels are so low that your body's making extra red blood cells. Purulent sputum, this is that green, thick mucus coming out, and it may be time to start antibiotics or culture it if you've had frequent antibiotics. Biochemical tests, so the comprehensive metabolic panel to help detect electrolyte disturbances, sodium, potassium, chloride, see if your blood sugar is elevated, or signs of poor nutrition. During an exacerbation, spirometry is not that helpful. As we recover, it can help guide us in terms of when it is time to go home. So in terms of treatment, oxygen, to keep that oximetry 88 to 92%. We're not looking for 100%. Again, that can shut down your respiratory drive. The use of bronchodilators and the use of steroids, all those in combination can reduce the length of hospitalization and get you home with more speed. The oxygen may be used at home as well. It may be that for a short period of time you'll need to be discharged on oxygen. So antibiotics, again, with a respiratory infection due to a virus, are not going to be helpful. But if there's increased shortness of breath, more sputum, and more purulence, this is where antibiotics may be helpful. And some people may require mechanical ventilation. This is where we try not to put tubes into the trachea. We try and stay away from invasive ventilation. And this is where just an external help, what's called non-invasive ventilation, a mask ventilation, or ventilation through your nose, can improve respiratory acidosis, can allow you to rest, let your respiratory rate reduce, allow you to rest, decrease that feeling of I can't get my breath, and decrease complications and the length of hospital stay. Non-invasive ventilation can decrease mortality, and really, again, that intubation, that's really a downhill course and something we want to stay away from. So again, in terms of hospital admission, if you or your caregivers, your son, your daughter, if you're having a marked increase in intensity of symptoms, we need to let people know. You may be heading towards the hospital. If you're gold stage 4, you have severe underlying COPD. Doesn't take much to get close to the table and fall off the edge. Onset of a new physical signs of fever, or more rapid heart rate, more rapid respiratory rate. And if you've seen your doctor and it's not getting better after several days, you may need to spend some time in the hospital. If you have other problems, lung cancer, diabetes, heart disease, these things, this COPD exacerbation may be enough to put you in the hospital. If you have a history of frequent exacerbations, frequent worsenings, you may need to spend time in the hospital. Older people, very fragile. It doesn't take much, and particularly if you're not around other people and you don't have caregivers, sometimes it's good to spend a little time in the hospital, having that case manager work with you, but particularly it's with this increase in symptoms. So if you have insufficient home support, that's really what we're trying to do with the visiting nurses and the case managers. So in summary, we've been talking about managing stable COPD, the goals of therapy, avoiding risk factors, the pharmacologic therapy, the non-pharmacologic therapy, and managing exacerbations. So there's consequences to exacerbations, so we need to assess early treatment, and the indications for hospitalization are severe exacerbation, not having someone to help you through this, a worsening after you've initiated treatment. So we're going to be right back. Welcome back. We've been talking about COPD, but I really wanted you to get a feel for the human side of COPD. With me today is John. I won't mention your last name. So tell me about COPD and the impact on your life.
Well, I was diagnosed about 5 years ago. I'd spent about 20 years in the military, and I didn't smoke prior to coming in, but all my friends certainly did, and it wasn't long before I was smoking about a pack a day for 10 to 12 years. And I was diagnosed with what they thought was asthma, but it was just a chronic history of lung infections and breathing difficulties for several years prior to me getting out. I subsequently went to the VA hospital where they diagnosed me with COPD about 2 years after I retired from the military.
So the military's changed, and I remember with the airport traffic controllers, they wanted to encourage smoking. It sharpened your brain, made your heart beat stronger, and also caused lung cancer, emphysema, heart disease, and osteoporosis. So what's happened with the military and smoking? How's that culture changed?
Well, ever since I can remember, I always aspired to be my leaders and my chiefs and senior enlisted managers. And so if you didn't smoke, you weren't considered a military man. So it wasn't uncommon to smoke in your barracks, in the office. Of course, everybody smoked in the cars, and it was the thing to do when you were out partying or out at the nightclubs. Since I've come in, the military, through all the armed services, the Army, Navy, Air Force, and Marines, have implemented very rigid standards of physical fitness and wellness. We have a number of wellness programs now in place, and it's become very competitive in terms of if you want to stay in the military, you have to compete with those soldiers, sailors, and airmen next to you for not only knowledge, but physical fitness. You have to compete with physical fitness testing and scores. You have to hit very high targets for push-ups, sit-ups, and your run. And if you have any type of respiratory difficulty, you're definitely at a disadvantage. So the smokers were certainly the first to go, and it's a much leaner fighting military now.
So what happens in your life? How has COPD affected your life in terms of?
Well, I had significant amount of difficulty sleeping. I have to sleep on my side just to get good air. I have been diagnosed with diabetes. I have high blood pressure as a result as well, I suspect. And I have been diagnosed with depression, which has all been advised to me that it's all interrelated. And of course, I'm concerned that my kids might actually inherit this negative and nasty habit as well growing up.
Do you have a primary care doctor? Have you had spirometry? Have they been, how did you go about getting diagnosed?
Well, I came in because I was told I might have a reactive airway or asthma, exercise-induced asthma. And after some incentive spirometry and some testing through the with the registered the RTs, our respiratory therapists, I was subsequently diagnosed, and so I go in regularly for spirometry testing and follow-ups. That keeps me breathing as best I can. I'm not carrying an oxygen tank yet, and I hope I never do. But
so, by stopping smoking.
That was paramount. I did participate in smoking cessation classes. I was given patches. I was given education and counseling. It's been effective. I stopped smoking immediately. I do want to live a long and prosperous life, and I feel that that was probably the first step to managing my COPD.
And how about exercise? So with the depression, oftentimes people don't want to leave the house. So how did you incorporate exercise into your daily life?
It was difficult. After I was diagnosed, I thought it was a death sentence because I know several of my friends who were diagnosed and they since passed away as a result of it. I didn't want to get out of bed. I didn't want to leave the house. But I was forced to just walk around the block, literally baby steps. And one walk around the block became 2 and 3 and 4. And now I'm up to about 1.5 miles every day, and I do that about 5 to 6 days a week, and I feel it's very effective, as does my doctor.
Now, what are some other things you do? So when you go to your doctor, does he keep track of your flu vaccine and so forth?
He's recommended that I get it, and I do. I was getting the influenza vaccine, which they say will help me manage my COPD. It seems like for the first several years after I was diagnosed, I was getting sick as a result of it. But at the end of the day, it was proven to be much more effective. And so I listen to my doctor. I listen to everything that he says. I take it as a biblical word, and I don't deviate from that. So he obviously knows how to treat me, and I definitely respect that.
Well, John, thank you so much for coming. I know this has a big economic impact on your life, time missed from work, insurance, co-payments, all those medications, but you're doing a great job, and I really appreciate what you're doing for yourself and for your family as well. So Ventura, we're going to be right back. Welcome back. We've been talking about COPD here in Ventura County and the grant that we've received and the extra resources we're going to be providing the community. We're going to end this segment by talking about managing comorbidities and really try and wrap up the things that we've been covering over the last hour. So our problem is that COPD is oftentimes not present all by itself. There are comorbidities, and these influence prognosis. So in general, it shouldn't alter the therapy, the use of the long-acting beta agonist and inhaled corticosteroids, but we have to treat those comorbidities as if they didn't have COPD. So the big one, cardiovascular disease. So again, as we age, this could be ischemic heart disease, or the blood vessels supplying the heart itself may be smaller. If you've had a heart attack, heart failure, if you've had an area of your heart called the atrium, this is where the conducting factors come through. So atrial fibrillation, a shaking of the heart rather than the squeezing and moving blood through, and high blood pressure. These are the major comorbidities, things that we see as we age, and this is really the most frequent comorbidity. So using a cardioselective, so something that's specific to the heart, beta blocker treatment, despite beta blockers in general blocking my treatment for COPD, these are really in the balance. These are the most effective drugs and outweigh the potential risks in patients with severe COPD. Osteoporosis, we take a look at DEXA scans. We want to make sure we know what your bones are like and initiate vitamin D treatment and calcium as needed. Lung cancer is more frequent in patients with COPD, mainly that risk factor of increased exposure to all the poisons that are in tobacco smoke and are more common, the most common cause of death, even in patients with mild COPD. Serious infections with nasty gram-negative bacteria are frequent and may require very strong antibiotics, particularly with a continued exposure to antibiotics. And then metabolic syndrome and diabetes. So particularly as America has gotten bigger and bigger, the amount of stress, your own corticosteroids blocking the effect of insulin, diabetes is a very important comorbidity. Spirometry, we need to have access to that. Your doctor needs to have access. It should become the 6th vital sign in your doctor's office, an FEV1 to FVC ratio, or an FEV1 to FEV6, the amount of time it takes to get out air in 6 seconds. This needs to be a regular part of your screening, and if you're not getting it, it's time to ask for it. And then the other is having the resources in the community through Better Breathers and others for pulmonary rehabilitation and being able to stay physically active. We're relatively fortunate here in California compared to my friends in Chicago where it's 10 degrees outside. We need to stay active, and we have that advantage here. So just in summary, to assess COPD, we need to assess the symptoms. We need to assess the degree of airflow limitation with the spirometry. We need to look at the risk of exacerbations and reduce them with some of these more preventive medications, the inhaled corticosteroid, LABA combinations. And we need to treat the comorbidities, the heart disease, the diabetes, depression, osteoporosis, to stay a step ahead. So to prevent and reduce the healthcare costs, we need to treat these exacerbations. We want to minimize their impact on your life by providing early access to care. We want to prevent the development of subsequent exacerbations, and we want to look for the comorbidities. When you go into your doctor, make certain that they're doing a complete assessment. Ventura, time for you to get moving.